Professor of Medical Genetics at Tehran University of Medical Sciences and head of the leading house for Iran North America Academic Partnership, which has planned and organized this series of educational programs. First of all, I would like to thank you for joining us in our webinars, and we are honored to have you all with us. We are pleased to present the fifth part of the webinar series entitled How to Deal with a Set of Hematologic Malignancies, which provides a great academic opportunity for Iranian hematologists and fellows to interact as well as share and exchange their knowledge and experiences with Iranian American experts in the field of hematology. Here, I would like to mention that this series of webinars on hematologic malignancies is scheduled and will continue until November. Actually, we have published a booklet on this series with some information on the details of the program, such as the timetable of the webinar, speakers, moderator, and so on. And we will upload this booklet on this platform at the end of this session and also provide you with the link by which you can access this booklet and download it to get more information about the program. And the good things to know is that because of the importance of these webinars, we plan to run these webinars with updated information every year. I also need to mention that in the near future, we are going to come up with other series of webinars on non-hematologic malignancies and solid tumors, as well as other clinical subjects. So stay tuned for our announcement on the upcoming programs. Okay, now let's begin our today's webinar. But before we start, I would like to express my special thanks to Dr. Maziar Shadman, Associate Professor of Medical Oncology at the University of Washington, who will be the moderator of this webinar today. And also my appreciation to the Appraise to Raise team and the Tehran University of Medical Sciences Vice Dean for Educational Affairs of International Campus for their great effort and support making this program possible. I should also add that we will provide a participant of this webinar who will be present for more than half of the time of this session with a certificate of attendance. Here I pass the microphone to Dr. Shadman to start the program and also to introduce our invited speaker, Dr. Ashkan Emadi. Dr. Shadman, please.
Thank you, Dr. Yaghmai, and it's my pleasure to introduce our speaker today. He is very special. He's a great friend, also has been a great mentor for me personally, and also a role model for many individuals like me who are in academics in the United States. Dr. Emadi is a hematologist, a medical oncologist, and an organic chemist who's a professor of medicine and also a professor of pharmacology at the University of Maryland School of Medicine and Greenbaum Comprehensive Cancer Center. He serves as an associate director for clinical research and also director for translational genomic lab at the University of Maryland Greenbaum Comprehensive Cancer Center. Dr. Emadi's clinical practice is focused on acute leukemia. Also, his research, his area of expertise includes molecular pharmacology, cancer metabolism, and regulatory aspects of cancer-related clinical trials. He's very active in translational investigations, and his lab research is focused on glutamine metabolism, overcoming resistance to FLT3, BCL2, and MCL1 inhibitors, and also in cancer immunotherapy, including bispecific T-cell engagers in acute leukemias, and also targeting indolament pathway. Dr. Emadi is a graduate from Tehran University when he obtained his medical degree. He has a PhD in organic chemistry from Illinois Institute of Technology. He finished his residency at University of Cincinnati and hematology and medical oncology fellowship at Johns Hopkins School of Medicine. He worked as a medical officer at the FDA, working on hematologic malignancy medications before joining University of Maryland. He has authored more than 120 publications as manuscripts and number of books and book chapters. You may be familiar with his chapter on acute myeloid leukemia in the Winthrop textbook of hematology, and He has authored many very helpful and practical books on pharmacology of cancer drugs. So it's my pleasure to have him today as a speaker. I will be serving as the moderator. So after his talk, we will be going through the questions from the chat box. We may have the opportunity of opening the mic for the audience to ask their questions. Dr. Emadi, microphone is yours.
Thank you very much, Dr. Shalman, for a very nice introduction. Dr. Emadi, thank you very much for the kind invitation, and I'm honored and privileged to give lecture back to my colleagues in Iran. As Dr. Shadman said, I obtained my medical degree from Tehran University of Medical Sciences, and it's always a pleasure to go back and see some of the familiar friends. So today we are going to talk about ALL in adults. I made it somewhat interactive. We do a lot of the case-based slides, as well as some of the evidence around how I treat hematologic malignancy. Almost all of the cases that you see, they are my own patients. And of course, these are the de-identified history of the patients, and this is only for educational purposes. So without further ado, let's start. So the case one is a 29-year-old man with no significant past medical history, presented with 4 weeks history of sharp and stabbing abdominal pain, night sweats 3 to 4 times per night, generalized body ache. He was afebrile, had a normal vital signs and normal physical exam. Chest X-ray, EKG, and abdominal CT essentially showed no acute pathology. CT of the chest showed bilateral ground glass opacity. CBC showed mild thrombocytopenia. Hemoglobin was 9.9 gram per deciliter. Y count was 7,700 per microliter. Peripheral smear showed a typical lymphocyte with 30% blast. Bone marrow aspiration and biopsy showed hypercellular marrow for age, and it was involved with B-cell ALL. Had a normal male karyotype, and his spinal fluid had no evidence of ALL. So what are his options, and what is the goal of therapy? So the options are induction chemotherapy, and we are going to talk about the pediatric-inspired. This young man is alive now 8 years without a transplant. So the goal of, and he's essentially cured. So the goal of therapy for him is to cure him without allogeneic stem cell transplantation. So a few introductory slides about ALL that I will quickly pass through them. The American Cancer Society estimates the number of ALL patients in the United States approximately 5,700. Out of that is approximately 1,600 death happen, so 25% death rate. And in the United States, the average person's lifetime risk of getting an ALL is slightly less than 1 in 750 people. And as you see on the right side of the slide, ALL peak in the childhood, then it come down during the midlife, and then toward the end of life, after 60, 65, the incidence slightly increases. Dr. Shadman, do you see my my cursor on the computer?
Yes.
Okay.
Yes, we do.
Okay. So 85% of ALL are BALL, 15% are T. Out of the 6,000 new cases of ALL in the US, approximately 3,700 are childhood and 2,200 are adult ALL. 75% of these new annual cases of adult BALL are Philadelphia chromosome negative. So when we talk about the chromosome, so I think that it's important when we look at some of the lectures saying that, for example, the hyperdiploidy, high hyperdiploidy, what really they mean here. So the rule of thumb is simple. So 46 chromosome, we as human beings, we have 46. So that's diploid, half of that is haploid. 23 times 3 is 69 triploid. And in between the number of chromosomes, there are some exceptions and the number of chromosomes are there. But this is as a rule of thumb. When we say, for example, high hyperdiploidy, we mean that each cancer cells has approximately 50 to 65 chromosomes. So this is important as an introduction, how a cytogeneticist, for most part, counts the chromosome. Based on the WHO criteria, ALL is divided into the BALL, non-otherwise specified. And if there is some recurrent genetic abnormality, such as Philadelphia chromosome or MLL gene rearrangement or the lysine methyltransferase 2A, which is on the chromosome 11, Q23, the subband 2 and 3 of the long arm of chromosome 11, and so on and so forth. And we are going to talk about this kind of newer entity, the Philadelphia-like chromosome, which brings a significant poor prognosis for a patient at the time of diagnosis. And then we have the T lymphoblastic leukemia. Out of that Philly-like or Philadelphia-like chromosomes, there are some kinase activating alteration that makes this ALL or lymphoblast resistant to the conventional chemotherapy. I put some percentage from one of the publications. For example, more than half of the Philly-like chromosome, they have the CRLF2 rearrangement. And here we see this quite often in young Latino or Hispanic population, that they have this CRLF2, which is unfortunately very resistant to chemotherapy or even immunotherapy or cellular therapy. I have later slides that how potentially we can target some of these kinases in case that the resistance occurs during the treatment. Again, very briefly, the immunophenotypes of the ALL cells, of course, they are myeloperoxidase negative. And if they are positive, and then if they have some of the lineage defining, for example, if they are myeloperoxidase positive and they are cytoplasmic CD3 positive, we call them T-MPAL, mixed phenotype acute leukemia. But for most part, the ALL are MPO negative, they are TDT positive. They may express some of the myeloid markers such as CD13 and CD33. The most important part for the BALL is that they are 19, 20, and 22 positive. Again, there are exceptions. And mature B cells such as Burkitt, they have TDT negative. And of course, the TALL, they are, as I teach all of my fellows, I tell them that the single digit cluster differentiation, 1, 2, 3, 4, 5, all of these are related to the T cells. And as you can see here, the cytoplasmic CD3 is the lineage defining immunophenotype on the T cells. Now let's have a few slides talking about the prognosis. As all of us as oncologists know, age is very important. As you can see here, for example, this is every decade, age 1 to 10, 10 to 15, 15 to 25. As you see that the age increases, the survival of patients are decreasing. Of note, if you look at the reference of this publication, this is in 2013, which in that time, none of the immunotherapies that we are going to talk about this later on, they were approved and they were used. Neither some of the chimeric antigen receptor T cells were available. So this is some of the historical data just based on the chemotherapeutic agents. What about the cytogenetic? There is no uniform cytogenetic across all the study, but for the most part, the favorable cytogenetic in ALL is considered high hyperdiploidy and then translocation between chromosome 12 and 21. And some of the poor cytogenetic, I list them here: Philadelphia chromosome 119, involvement of the MLL gene, near triploidy, low hypodiploidy, and more than 5 abnormalities, which is the complex karyotype. And I gave you the definition of how we count those chromosomes. Now, if we combine the age and cytogenetic, you see why probably some of the ALL in children are one of the reasons that it's better treatable and has a better prognosis is that the ALL in children is essentially a different disease than in adults. For example, more than in translocation 12 and 21, which is considered a favorable translocation, it occurs in about 1/5 to 1/4 of patients in children, in pediatric patients, versus that translocation is very rare in adults. On the opposite side, the Philadelphia chromosome is very common in adults, but you see this rarely in children. So there are, based on cytogenetic, there are differences between pediatric and adult ALL. Now, 2 or 3 slides about when we talk about the definition of response, including complete remission, what we mean. And all of you know this is a preaching the choir. What's the definition of the CR is, of course, the marrow has less than 5% blast. There's no extramedullary disease. Platelet count is more than 100,000. Absolute neutrophil count, ANC, is more than 1,000, and people are transfusion independent. And all of us know that at the time of complete remission, people, they have approximately 100 million to 1 billion cancer cells, leukemia cells left in their body. So that I put it down here that the remission does not mean cure. And that's the reason that we do further therapies such as consolidation. However, because of the chemotherapy and because of essentially the failure of the leukemia community to provide better drugs historically, then we went down for a lower hanging fruits. And that was hence generated some responses that they are less robust than CR. For example, CRI, which is complete remission with incomplete hematologic recovery. And here your platelet count can be less than 100,000 or your neutrophil can be less than 1,000. One thing is important that when we say that the platelet is less than 100,000, there's no lower limit on that. You can have a single digit platelet or have absolutely no neutrophil and you're still being CRI. And hence FDA and other regulatory agencies such as European Medical Agency, they do not consider CRI, CRP as a valid endpoint that reasonably likely can be used as a surrogate marker to predict better clinical outcome. And hence, if you look at the literature, before 2014, there was no CRH. Myself and a few of my colleagues, we essentially invented this CRH, which is complete remission with partial hematologic recovery. And here you need a neutrophil count more than at least 500, and your platelet count should be more than 50,000. I often joke that I call this CR Bahamas, because if you are in CRH, you can go, your life does not depend on me, an IV antibiotic, prophylactic IV antibiotic, and my infusion to give you platelets. This is, and later I tell you that why FDA considered this as a endpoint. And then later on, when this CRH started with at the first approval of the Blinatumomab, now the CRH actually has leaked to some of the approval for the AML, such as for venetoclax and IDH inhibitors and FLT3 inhibitors. Although in AML, the literature or evidence for the importance of CRH is less robust. So these are all the CRH, these are all morphological response. However, we cannot talk about ALL and not talk about MRD. Minimal or more accurately measurable residual disease. It can be measured by flow cytometry, by PCR, or by some of the leukemia-specific transcripts. And I here put comparison between the PCR for BCR-ABL, and some of the multi-parameter flow cytometry and their level of detection. This is my former colleagues at Hopkins. Mike Borowitz published this data back in 2008, and this is from the pediatric group in the COG, Children Oncology Group. And as you can see, when you have the MRD negativity, your survival is much, much better than, for example, your MRD is more than 1%. And if you pay attention to this, FDA and some of the regulatory agencies, they accept this 0.01%, which is essentially, because if percent has 2 zeros, so it's less than 1 in 10,000 cells. So if your whatever technique that you're using is, you can detect more than 1 in 10,000 cells, that's acceptable MRD. And then there is this wonderful, beautiful paper that published by Berry and et al. In JAMA Oncology, and I urge all of you to read this. This is a meta-analysis of 39 publications, more than 13,000 patients, 16 adult studies with about 2,000 patients, 20 pediatric studies with more than 11,000 patients, and 3 mixed. The study, as you see here, the event-free survival, the hazard ratio for achieving MRD negativity was 0.28. So that means that you improve the survival by 72% based on this Bayesian credible interval if you achieve MRD negativity. And the same hazard ratio occurs with the overall survival. So there are some debates that when we measure the MRD, is it post-induction, post-consolidation? Is it based on the pediatric-inspired, based on some of the hyper-CVAD-like regimen? All of those is that how I consider MRD is post-induction. If you are MRD positive, post-induction chemotherapy, that is in my mind, the poorest prognosis. Mike Loken, my friend that is in Seattle, and he does a lot of MRD, he did the study on children data and showed that if you're MRD positive post-induction 1, doesn't matter what you do, patients unfortunately do very poorly, although that may change with some of the CAR-T availability. But the message here, I tell all of my community oncology colleagues here that if you cannot measure MRD, you better not treat patients with ALL, because considering cytogenetic, age, T versus B, all of those, as you can see here in this table that from the Berry et al. Doesn't matter if you measure MRD by flow, PCR, induction, consolidation, Philly negative, Philly positive, B versus T, randomized trial versus not. If you look at everything, MRD wins. So if someone asks you what is in 2021, what is the most important prognostic marker for ALL is post-induction MRD status. So now after those introduction, let's move on to how we treat newly diagnosed adult patients with ALL. The factors that I keep in mind are age. Is this person is it medically fit? Has no adequate organ functions or not? What's the status of the Philadelphia chromosome? And what is my goal of care? Is it the definitive treatment versus palliative treatment? Regardless of what I do for patients, I definitely give multiple CNS intrathecal chemotherapy for CNS prophylaxis. In our hospital, I'm probably doing more intrathecal chemotherapy or lumbar puncture than our neurologists. And I urge you to do this again. If you are treating patients with ALL, either your interventional radiology or yourself should be able to perform lumbar puncture and administer intrathecal chemotherapy. Now, let's start treatment of newly diagnosed ALL with Philadelphia chromosome negative. So age, we say, is it younger? And a lot of people say, what do you mean by younger? Is it less than 30, less than 40, less than 50, less than 60? What is the adolescent young adult? In my book, and the major part is that does the age, can people tolerate asparaginase product? There is a study, the CLGB 10403 that I'm gonna shortly discuss. They had patients up to age of 40. Dana-Farber protocol have up to age of 50. So documented, a lot of people, it's appropriate to use the pediatric-inspired regimen up to age of 50. And I'll tell you that I have a clinical trial now that FDA actually requests us to go up to age of 85 and to try asparaginase in those population. Is this Philadelphia chromosome positive or negative? And all of us remember that the B-cell ALL, most of the Philly positivity is in B-ALL, but don't be surprised that actually I have seen 2 or 3 patients in my life that with T-cell ALL, they are Philadelphia chromosome positive. And some people debate that, is those T-cell ALL Philly positive, are they truly de novo ALL or they are CML in a lymphoid blast crisis? And what is my intent? Can I cure these patients without transplant? Right now, actually, I do less and less transplant for patients for ALL, unless they are, as I said, MRD positive post-induction. But at the time of diagnosis, these are the people that I consider that if I'm successful to put them into remission, I take them to transplant. I see more and more patients with P53 mutations, and the majority of those patients are treatment-related ALL. All of you are familiar with the treatment-related AML. I think that this word will be coined very soon in the medical literature. I've been using this in the last 2 or 3 years. We have published on that. People that they were treated for multiple myeloma, for breast cancer, they, instead of developing MDS or AML, sometimes they develop ALL, and those people with therapy-related ALL, they have complex karyotype, and majority of them, they have the P53 mutation. Philadelphia chromosome, that's in the literature. If somebody has a Philly positivity, you should consider them to take them to allotransplant. With some of the modern therapy that we have, I do less and less transplant my patients with Philadelphia chromosome positivity. That's not a standard of care, but this is, I think that the field will move on. Definitely 4 and 11 is a very bad player, and Philadelphia-like ALL is also a very bad player, and you should think about donor search at the time of diagnosis. So chemotherapy regimen, essentially for newly diagnosed, no one regimen has prospectively been shown to be superior to another one in any of the randomized studies. And I put 4 of the common and older regimen here. And as you see, all of the CR rate and 5-year overall survival is different. However, in the book that we did, this is the first illustrated book for acute leukemia, both pediatric and adults, AML and ALL. Me and Judy Karp did this. In the chapter that I asked Archie Blyer to write this for adolescent and young adults, he compares some of the pediatric regimen with the adult regimen. And as you can see, this is beautifully, Archie shows that the pediatric regimen, and this is the, at least in the United States, the hyper-CVAD regimen. And he calls this cliff, which happens between age of 16 and 21. There's a significant cliff. And although it might be related to the biology of the disease, but the regimen that we use is different. And I tell you that more and more people are using the pediatric-inspired regimen for people up to age of 50. So this is very very important. And again, if you see this, this is some of the older historical CALGB studies, such as 8811. And then you see this for the CALGB 10403. So CALGB 10403, published by Wendy Stock, a good friend of mine from University of Chicago as a first author, and it was run by CALGB group. It's a very intense regimen. Essentially, if I see a newly diagnosed patient less than age of 60, I have to have a reason. Either I have a clinical trial, which most of the clinical trial that I'm the PI of, they have their backbone, they're using this regimen. And this regimen is coming from a arm of a children oncology group, which was high risk. Again, I put it here, it's in Blood, published in April of 2019. It has, the importance of this is beyond the induction therapy, the rest of regimen is completely outpatient. I never use G-CSF or other growth factors for my patients. And then we will see people here in the Pediatric-inspired, they receive until the end line 24 intrathecal chemotherapy. And that's the reason that presence of the CSF involvement at the time of diagnosis, when you use this, is not considered a poor prognosis anymore. And here is the data that never been repeated with any study in the modern time for the treatment of adult ALL. And here the overall survival, the median overall survival has not reached. And if you look at the 50%, if you look at coming in here, at least after 5 years, 6 years, 7 years, 8 years, 9 years, people, more than 50% of people are alive. And that's fantastic. If you have this data, granted, this is not a randomized study, but if you have this data in hand without a transplant, you should have a very good reason not to treat patients off clinical trial based on this regimen. And they found out only 2 pre-treatment factors that were associated with poor prognosis. One was obesity, and I tell you that why I think obesity was poor prognostic factor, because people could not receive appropriate asparaginase. And the next one was the Philadelphia-like. So because a lot of my research is on the asparaginase product for the glutamine depletion, as Dr. Shadman very kindly mentioned, these are some of the different asparaginase that they are approved. These are the bacterial enzyme that either are isolated from E. coli or Erwinia chrysanthemi. Now the asparaginase is isolated from Erwinia chrysanthemi. The name to remove the confusion, the name is chrysantaspase. I have several clinical trials that use asparaginase product for treatment of AML. And I think that before I die or during my lifetime, I should be showing to the world that asparaginase can have a significant role in treatment of AML as it does in ALL. The short-acting E. coli asparaginase is not commercially available in the US. The most common one is peg-asparagase. And the new one, which is the same E. coli, the same pegylated polyethylene glycol, but the linker is different, is cal-asparagus pagol. The brand name for that is Asparaginases. It's approved for ALL up to age of 21. We have a clinical trial here, us and 5 other centers in the country, that we use the backbone of the CALGB 10403, but we substitute the peg asparaginase with the cal-asparagus pagol, and the study is going on. And this is the study that I told you that it's going to enroll a few people over age of 60 years old. So how asparaginase works, the medical literature or urban legend says that the lymphoblasts here, they are addicted to asparagine. and they cannot make their own asparagine. Hence, if you give asparaginase that can convert asparagine in the plasma to aspartate and ammonia, then you deplete or deprive your lymphoblast from asparagine and they die. That is, in my mind, is a very oversimplistic view. Asparaginases, all of them, are amido hydrolase, so they convert all of the amides to acid and ammonia, including glutamine, which is the most abundant amino acid in the blood. And the reason that asparaginase work, because they deplete or decrease both plasma asparagine and glutamine. And because asparaginase is an enzyme, there's a study showing that, you know, if people develop antibody against this asparaginase, we call them silent deactivation. If you switch them from E. coli asparaginase to Erwinia asparaginase, actually the event-free survival improves. This is a study published in JCO. At our center, we check the nadir serum asparaginase activity beyond the second dose, 7 days and 12 to 15 days post. And we are looking for the level which FDA and other regulatory agencies looking at this, and that's 0.1 international unit per ml. If you go below that, your asparaginase is not able to deplete asparagine and glutamine. And this study shows that switching it to Erwinia provides better clinical outcome. Also, if now I am telling you that you should use CLGB10403, which has significant asparaginase product, asparaginase is not an easy drug to give. So you have to do a lot of monitoring. So I quickly go through this monitoring. We published this last year as a white paper, and what we do, because our center, we use a lot of asparaginase, as I told you that for AML and ALL. So just go quickly over those. We cap our dose in one vial, which is 3750 international unit, regardless of patient's weight or body surface area. We do not give in each injection more than 3750. We pre-medicate people with acetaminophen, hydrocortisone, and diphenhydramine to prevent the hypersensitivity. And if people develop hypersensitivity, we permanently discontinue that. We monitor the liver enzymes and direct bilirubin very aggressively. Again, the paper is published. You can look at the detail. If the bilirubin, the direct bilirubin goes more than 3 milligram per deciliter, or liver function test goes more than 3 times upper limit of normal, we use the vitamin B complex orally and levocarnitine. Why is that? There is a carnitine shuttle in the mitochondria that, by using the combination of the B complex and carnitine, essentially you increase the metabolism of bilirubin. There's a very scientific mechanism of action behind this. We monitor pancreatic enzymes. If people develop clinical pancreatitis, more than such as with abdominal pain or CT scan shows hemorrhagic pancreatitis, we permanently discontinue. Then about the fibrinogen use to prevent bleeding, we kind of do less and less of this. We check the fibrinogen, but I'm hesitant to give cryoprecipitate if fibrinogen is less than 80. There's a beautiful study published by Orvain in July of last year in Blood, and showing that actually aggressively trying to replete fibrinogen may increase the probability of the venous thromboembolism. I put people on the low molecular weight heparin, weight-based, as long as they're not bleeding and their platelet count is more than 30,000. And we monitor the antithrombin 3. And because the asparaginase, one of the important things that asparaginase causes blood clot is that it depletes the antithrombin. And if in our center, if the antithrombin goes less than 50%, we replete that. And it's not an expensive product, believe it or not. And our goal is to increase it to 80%. So doing all of these things, knock on wood, we have not, in the last 6 or 7 years, we have not seen any of the thrombohemorrhagic adverse events related to asparaginase, either in ALL or our clinical trial with AML. Now let's move on how we treat Philadelphia chromosome positive ALL. So if people are younger and medically fit, can they tolerate conventional chemotherapy or not? Again, what's the curative intent? As of right now, for Philadelphia chromosome, we use the allogeneic stem cell transplant. What about if they are older and or medically unfit and not a candidate for allo transplant? These two slides showing essentially that adding imatinib to the backbone of either pediatric regimen or hyper-CVAD improves clinical outcome. That's no brainer. What about Dasatinib? That's the drug that I use for upfront Philly positive ALL. It has a broad spectrum kinase inhibition. It crosses blood-brain barrier. With hyper-CVAD, with 14 days on, 1 day off, the CR rate, a small sample size, Farhad Ravandi, which is gonna give you, I guess, the AML talk later on. They published that in Blood in 2010, complete remission of 94%. And then there is another study published in Blood that's essentially prednisone with dasatinib, and the CR rate is 100%, and 20 months overall survival is approximately 7%. And 12 out of 17 people who relapse on this regimen, they develop actually the T315I mutation, which is confers resistant to all of the tyrosine kinase inhibitor except for ponatinib. Then what about the Philly-like therapy? Again, depends on Philly-like is a basket that we put it in there. It's important that if you can do the gene mutation, if they have ABL1 or CSF1R or the platelet-derived growth factor, you can use some of the tyrosine kinase inhibitor. If they have CRLF2, JAK2, or the mutation in the erythropoietin receptor, some of the JAK inhibitor may be useful. So again, the Philadelphia-like, and unfortunately, the literature on using some of these targeted therapy in Philly-like, it's very sparse. But out of desperation, and I told you that this is a very bad player, so you try to find a target. What about Rituximab in ALL? Essentially, the message for you is that the approximately 40 to 50% of the BALL, they present CD20. 100% of the bear kits, they have a CD20. And the message, MD Anderson, Debbie Thomas published this back in 2010. Their pathology says that more than 20% CD20. And I tell you that this 20%, can be tweaked. Essentially, I use Rituximab for any percentage. If my hematopathologist tell me that if they find 5% CD20, I'll use Rituximab. This is one of the studies showing that adding Rituximab to the backbone of the treatment improves the clinical outcome. This is a study by Dieter Holzer from Germany, showing that essentially with a standard or high risk, whether you use Rituximab or not, the CR rate doesn't matter that much. However, the 5-year overall survival in each group is significantly better. For example, 71 versus 57 here is 55 versus 36. So that tells you that Rituximab probably somehow targets the stem cells of the ALL and provides a better, longer overall survival and event-free survival. So any level of CD20 whether you use CLGB10403 or hyper CVAD or any regimen that you are using, if you have a CD20, I would add rituximab to the backbone of the treatment. This is another study, age 18 to 16, newly diagnosed, multi-center, randomized, pediatric-inspired dual regimen, and saying that adding rituximab to the backbone of the pediatric-inspired is also improves the event-free. This one was the plenary session abstract number 1 in ASH 2015. 2 slides on the role of the transplant for ALL. They're the best study that I could find. A study was published by Gupta and Jacob Rowe, published in Blood 2013. And they had a meta-analysis of many articles. And they showed that here, they said that the matched siblings, so not match unrelated, not haploidentical, matched sibling myeloablative, not a reduced intensity, improved survival only in younger people, less than 35, which unless there is a reason that you should transplant them, such as the P53 or 4 and 11, you should not consider these people for transplant, only provides about 10% improvement. And they showed that there's no benefit at all in autologous stem cell transplant for ALL. Actually, chemotherapy performs better than autologous transplant. And here is the NCCN guideline. I put it here for you, which I not necessarily agree with the lower part here. It says that if people achieve CR, people less than age of 65 continue multi-agent chemotherapy or considered allotransplant if it's available, particularly for MRD positive. I agree with that, but not with the high WBC and those poor risk cytogenetic that I told you. So this is the NCCN guideline. And Philly positive, essentially, they're saying that if people achieve CR, as of right now, I told you that in the future, this may change, but as of right now, the standard of care is to take them to allo transplant. Case number 2, 51-year-old man, history of hypertension, kidney stone, diagnosed in mid-2011 with Philadelphia chromosome BALL, treated with hyper CVAD, achieved and remained in CR, continued on maintenance therapy, and finished the maintenance. 3 years later, summer of 2014, presented with cytopenia. Bone marrow showed that he has a relapsed ALL with more than 90% bone marrow cellularity. These are some of the immunophenotypic features of those, negative for CD20. Cytogenetic did not show Philadelphia chromosome, but showed deletion of the 6q and monosome and 14q and monosomy 7. He was reinduced by ifosfamide, mitoxantrone, and etoposide, the regimen that my friend Gary Schiller in UCLA developed. However, he re-incurred persistent cytopenia and repeat marrow showed that he has a persistent ALL. And at this point, what are his options and what's the goal of therapy? He was referred to me, by that point, he was treated in the community, and at this point, he was referred to me for a Blinatumomab clinical trial. So his options now, they are at least 2 or 3 very good options, and the goal of therapy for him is still curative with some of the immunotherapy that we have, followed by allogeneic transplant. So essentially, the goal of if people they are relapsed, the goal is that to put them into the second complete remission and then take them to transplant. And these are some of the historical conventional chemotherapy-based regimen. And as you can see, I provided the references here. The rate of the achievement of the second complete remission is approximately around 40%, but 5-year overall survival is very poor. And now there are different options for treatment of relapse and refractory. And for the remaining of the talk in the next probably 15 to 20 minutes, we are going to cover this. So let's talk about the relapse and refractory. The first one is Blinatumomab, is a bispecific T-cell engager. So this is essentially the cartoon of Blinatumomab. One side of this is attached to the T cells, the other side is attached to the CD19 B lymphoblast, and bring the T cells to the lymphoblast. And as the immune cells are killing the bacteria, when these T cells are kissing the lymphoblast, they inject some of the lysozyme and granzyme into the B cells and they die. And they have shown that one T cell is enough to kill 4 lymphoblasts. So Blinatumomab is the fastest drug approved by FDA in all disciplines of medicine ever. And this is based on a phase 2 study of 185 patients, and Blinatumomab achieved this. This is when I told you that we invented the CRH. This is the first time, if you look at the CRH, came to the medical literature, and that was December of 2014. Before that, you have no news of the CRH in the literature. So the CR plus CRH was approximately 42%. Why FDA considered CRH, besides that I told you that the CR Bahamas is people are really transfusion independent, because approximately 60% of people that they had CRH, they achieved MRD negativity. So they probably considered this as an important endpoint. And they showed that out of the people that achieved CR/CRH, 3/4 of them, 75%, they were MRD negative. This resulted in an accelerated approval of Blinatumomab for Philadelphia chromosome negative relapse refractory BALL. When a drug, by the way, 10 seconds about the accelerated approval. Accelerated approval in the regulatory land in FDA started during the HIV time. And this is when you don't have a phase 3 study, but you'll show a very promising result in a single arm phase 2 study. And FDA wants your drug get to the market, help patients until you do your confirmatory study, which is a randomized phase 3 study to show actually the benefit of your drug. But until you perform your phase 3 study, your drug will be available in the market. The confirmatory study was published in March of 2017 in New England Journal of Medicine. It's an international group. First author is my friend Hagop Kantarjan from MD Anderson, and Max Top from Germany is the senior author. And they showed that in here, it was Blinatumomab versus the investigator choice of any standard chemotherapy regimen that you wanted. And there were 4 options. And essentially, the overall, there were 271, it was 2-to-1 randomization. And showed that the overall survival was significantly better. Number of deaths here was 61 versus 65. P-value was significant. CR/CRH rate was the same, 42% versus 20% with chemotherapy, statistically significant. MRD was also significantly better. So that was a tower study that we also participated in that. And this is the Kaplan-Meier showing that, again, the median survival at the time of follow-up was here approximately 8 months versus 4 months. And one thing is important, at 6 months, approximately 54% of people with Blinatumomab, they were still alive versus less than 40% in the standard of care. And this is the time that you can take people to transplant. And as actually they censored the survival at the time of transplant, and they showed that the Blinatumomab is still won against the standard of care chemotherapy. And then here the event-free survival was better too. Then later on that this is a blast study showing that people that they were in the CR but they were MRD positive after receiving 3 blocks of chemotherapy. This study was done in Germany based on the BFM regimen, which is similar to the Pediatric-inspired regimen. Blinatumomab converted people in CR1. Approximately 85% of people from MRD positivity to MRD negative. Hence, this has resulted in the accelerated approval of blinatumomab, the first time that any drug was approved for treatment of MRD positive by FDA is this drug, and its accelerated approval. The confirmatory study on this was the ECOG 1910 that we participated on that. The study is matured, is close to enrollment. We are waiting for the data become matured and we do the analysis, and hopefully in the next year or two, we publish the data. So there's this study that published recently in New England Journal of Medicine. This is the combination of dasatinib and blinatumomab for Philadelphia chromosome positive, newly diagnosed first-line therapy. So Blina is approved either for relapse refractory or MRD positive, but this Italian study, they used it with dasatinib for the first-line therapy. 65, so people received dasatinib and a steroid, similar to the study that I told you, followed by 2 cycles of the blin. 63% CR rate. That's the reason that New England accepted this paper. 98% CR rate. And at the finishing of the dasatinib induction, 29% achieved molecular response, and that 29% doubled to 60% after 2 cycles of Blina, and the result got better as people received more Blina. At a median follow-up of a year and a half, 95% of people were still alive. And this is revolutionary in my mind, that for Philadelphia chromosome positive ALL, a chemotherapy-free regimen, Blina plus a tyrosine kinase plus a steroid provides 95% overall survival at 18 months. 21 patients had grade 3 adverse events, 24 received allotransplant, and 1 died because of the complication of transplant. We published this in our institution. Everyone over age of 70 with Philadelphia chromosome negative ALL, they received single agent blinatumomab. We published this out of these 5 patients that they are all over age of 70. 3 of them are still alive today. And this is again available online, some of the patient characteristics, the karyotyping of those, and the outcome. We published this in 2020. Now we talked about blinatumomab. For your practical point, 2 things that you need to consider about blinatumomab, and this is from that New England Journal, the neurological events and some cytokine release syndrome. Let's show a few cases on those. So this one was one of my patients. So one thing that if you choose to give blinatumomab, if the patient can afford it, it's paramount important that you ask patient to write the writing sample every day. This is my patient, as you can see. It says that today is this, and I'm in the hospital. This is the handwriting. And as you see, by day 8, you see the handwriting becomes zigzaggy here. So I stopped blinatumomab. I gave a person, because of neurological syndrome, a little bit of dexamethasone. In my practice, I do not give too much of the dexamethasone because I still want to have the effector T cells alive. And then after 2 or 3 days, he became back normal. You see that back, his handwriting become normal. Blina went on, and then I increased the dose because for blinatumomab, you give 9 micrograms during the first 7 days, and then on day 8, you increase it to 28. And then unfortunately, around day 15, 18, he became, again, you see this around day 18, the handwriting became very poor, and person had essentially some seizure-like syndrome, and the family said that they want to withdraw the care. So unfortunately, the patient succumbed to his disease. Another case, a 84-year-old with B-cell ALL, we started on Blin. You see that this is at the beginning. After 7 days, tolerated well. On day 8, actually, you see that this is the handwriting, which is, as you know, I don't know, this is like more kind of a cartoon that children doing that. So I stopped it, and then I gave dexamethasone, followed the patient, restarted at the lower dose. Unfortunately, patient was able to continue the treatment and achieved actually complete remission after 28 days of blinatumomab. So for neurological symptoms, there are guidance in the FDA label. Use dexamethasone for neurological symptoms, but using it very judicially, not too much. Again, you don't want to kill your T cells. For the cytokine release syndrome, I never use a steroid. I use the tocilizumab IL-6 interleukin-6 receptor inhibitor. Let's do another case, case number 5. 49-year-old with past medical history of diabetes, feeling negative ALL, late 2015, achieved CR1 with hyper CVAD, received 6 more cycles of the hyper CVAD, multiple treatment delay because of infectious complication, relapse with feeling negative. Sorry, this should be E. BALL, after the first month of maintenance, blinatumomab was started, had some mild cognitive dysfunction, tremors, and dizziness on day 5. Blina, I continued Blina because this was all very mild. I continued Blina, very closely monitoring patient, symptoms resolved by day 7. I increased the dose to 28 microgram on day 8. Patient developed now moderate speech disturbances, altered mental status, and abnormal handwriting on day 11. I held the Blina, started dexamethasone every 8 hours. Symptom resolved on day 13. I reinitiated Blina, tolerated well, achieved the second complete remission after the first cycle of Blina. He received 3 cycles of the blinatumomab and IT methotrexate. I wanted to transplant him, but because originally his donor was his brother, then switched to sister, so I kept continuing giving him cycles of the blinatumomab. Now, Dr. Shadaman, would you like to ask people that this young man, what was his main complaint during these 5 or 6 cycles of the Blina? If you want anyone volunteer, what do you think, what do you guess that was his main complaint during the 5 or 6 cycle of Blina? Don't be bashful.
Yeah, you can type it in the chat box and I'm happy to read it.
Any taker? Okay, I tell you what was his main complaint. He said that he cannot have sex with his wife because blinatumomab is 28 days of continuous infusion that you have to carry with the pump on your belt, and it beeps all the time. So during this time that I give him the 28 days, he could completely not having any sexual interaction. And this is not something that you can do, but it's important that we pay attention to some of these social issues of our patient. After cycle 5, he developed blurry vision and right eye pain. MRI of the brain and orbit showed that he had right optic neuritis. CSF was negative, and essentially the differential diagnosis, it was not that. I had this hypothesis that because I kept giving this guy blinatumomab and kind of activating his T cells, I may have actually induced some autoimmune optic neuritis in this gentleman. And if you see something, you do all of your work. If it's the CNS is negative, I actually treated this gentleman with high dose of steroid, with pulse of a steroid for 5 days. The vision went on, and finally he got transplanted. He is still alive now. Case number 6, 32-year-old man with feeling negative BALL received a cycle of hyper CBAD, relapsed with the Y count of 226,000. After cytoreduction and hydria, he started on blinatumomab. He developed high-grade fever 3 days after initiation of blinatumomab. This one was, everyone said that, Dr. Emadi, this is the cytokine release syndrome. I said, sure, it can be, but I gave only one dose of tocilizumab, but I started him on cefepime. Blina is not that much of causing the myelosuppression, but he had 8 cycles of hyper CBAD. So I thought that this guy is still immunocompromised. So I increased the dose on day 8 to 28 microgram per day. 36 hours after I increased the dose, he developed high fever again, hypotension, tachycardia. Everyone said that this is a great treat, cytokine release syndrome, should go to ICU. I switched him from cefepime to meropenem, gave him 1 dose of tocilizumab. But by the morning that I started rounding again, the blood culture came back that he had ESBL producing E. coli. And actually, so switching that to meropenem was a wise decision. So not all of this fever during the blinatumomab is a cytokine release. Pay attention to your baseline of the neutropenic fever, particularly in the immunocompromised host. The next one is inotuzumab. It's a anti-CD22 antibody drug conjugate. That to that antibody anti-CD22, you have the calicheamycin. This is similar to the Mylotarg. And inotuzumab, again, is approved fully by FDA. This is the phase 3 study published in New England Journal of Medicine. And the dose is better given, it's easier compared to blinatumomab. You give 0.8 milligram per meter square on day 1, then 0.5 day 8 and 15, and then day 22, the 4th week, you give people rest. And then if based on their achievement of CR or CRI, you do the dose reduction beyond cycle 2 or not. So the importance for the inotuzumab compare again to the high dose Ara-C flag or mitoxantrone Ara-C is that inotuzumab achieves a significant, in the relapse refractory setting, much higher CR or CRI rates. Most of the CR are essentially the CRI, but 80 to 83% CR rate is very impressive CR rate in the relapse refractory in the people that they have their ALL still carry CD22. So if you look at this, if they ask you what is the only drug that in the relapse refractory setting shows improvement in overall survival, that's only blinatumomab. Besponsa, that's the brand name for the inotuzumab, did not show the improvement of overall survival in their phase 3 study. It shows the improvement, even with that 81%, it did not show the study. So that's, just for fun, I put one question here, and I'm gonna read this question for you. And that's kind of important when we read the medical literature, we pay attention to the details. So in that New England Journal of Medicine says that the second primary objective, which was to show that there's significantly longer overall survival with inotuzumab than a standard therapy at a pre-specified two-sided boundary of the p-value of 0.02 was not met. However, it was noted that the data for overall survival appeared to depart from the proportional hazard assumption, as reflected by the apparent heterogeneity in the curve for the standard therapy, which I showed you in the previous slide. Because of this, an exploratory post-hoc analysis of restricted mean survival time was performed, which showed longer mean overall survival with inotuzumab than the standard therapy. So when you read this, you say, huh, what does it mean? So Dr. Shadman, can you help me to see people, a few people vote? Now you torture your fellows, now the attending. Can you vote that which one of these options are correct?
Well, I don't see any responses, but I guess you, audience, you can just put the response in the chat box and we can count them if you see them. Maybe Dr. Emadi, if you can go, do you want to go through the responses, or maybe in the interest of time, just let the...
in the interest of, I give you the answer. The answer is that this essentially what they meant by this, you see that the standard care, they kind of like moved on and then out. So they departed from that assumption of the proportional hazard ratio, and they did something else, which was that restricted mean survival. And the p-value, that the answer is E. The p-value of the 0.05 was done using a post-hoc analysis and should therefore be taken into consideration with caution. That was not a pre-specified endpoint. One thing for inotuzumab that you need to pay attention compared to a standard of care in that innovative study in the New England Journal of Medicine, because of that calicheamycin backbone, it can cause the veno-occlusive disease or SOS in the liver. And there's a black box warning on that, that people that you are putting into remission with inotuzumab, you have to give them 4 to 8 weeks before you take them to transplant, because the mortality rate post-transplant because of VOD that people receive inotuzumab was significantly higher than the standard arm. So about the inotuzumab, this is similar to the Mylotarg. Whenever you hear about the calicheamycin, that causes the veno-occlusive disease in the liver. Now, very quickly, there are 3 accelerated approval for ALL that they have not been confirmed in the confirmatory phase 3 study. So they are still accelerated approval. That means so-called conditional. So their effect has not been shown in the randomized phase 3. The first one is clofarabine, nelarabine, and Markibo, which is the liposomal vincristine. Quickly, clofarabine is a halogen decorated purine analog. You have a chlorine here and you have fluorine here. It's very similar to cladribine and fludarabine. The study is approved based on a phase 2 study of 61 pediatric patients. And the CR plus CRP rate is, as you can see, is approximately 20%. So this is a, it's not that much available, it's very expensive. And now, of course, these are all approved before the Blina or inotuzumab. So it provides a CRP rate of approximately 20%. Nelarabine was approved in 2005. It's a prodrug. And because this adenosine deaminase, they are enriching the TALL, nelarabine inside the TALL gets converted to ERA G. This is similar to ERA C that we use the cytarabine. This is guanosine arabinoside. And the phase 2 study, they had, again, numbers are very small, 39 patients, 28 of them, they had TALL, 11, they had T lymphoblastic leukemia. They gave 1,500 milligram over 2 hours on day 135 and repeated every 3 weeks. And then again, people, they had more than grade 2 neurologic toxicity, they discontinued. Nelarabine, I'll tell you that has a very significant both central nervous system as well as other neurological toxicity. CR rate here is approximately, again, 21%. We published a patient with early T precursor ALL. The patient, as you can see, in 2003 was diagnosed with ALL, achieved CR, relapsed, given salvage therapy, and then went to transplant, relapsed again, given salvage therapy, 10 years in remission. Now in 2016, the patient came to me. I gave him nelarabine. I put him into remission, but I essentially made this poor gentleman, he was approximately in that time, I guess 75 years old. I made him wheelchair bound. I gave him 2 or 3 cycles of nelarabine. He could not move below his waist. Nelarabine, if you want to give it, has some decent activity in TALL, particularly the other salvage therapy are all for BALL, but pay attention very much to neurologic toxicity. After that, I said, okay, no more nelarabine. We gave him DLI, and then he relapsed. But because he had this CD33 positivity, which was a lot on this T precursor cells, I believe it or not, I gave him Dasatinib and DLI, and he achieved CR, and he just recently passed away, I think at age of 81 or 82 from non-leukemia, from some other complication. I think he had an atrial fibrillation or something. So you can use, in the presence of not having that much options for ALL, you can use nelarabine. Finally, Markibo or liposomal vincristine was done in a phase 2 study of the single arm, 65 adults, 85% of them, they were BALL, 15 were TALL. Here they had second or greater relapse. And the important part, if you have Markibo, I don't know you have it or not, it's very easy to make. It's really combining the some liposome with vincristine. You give it as a monotherapy. The dose is 2.25 milligram per meter squared without capping. You don't cap here, such as we do for the regular vincristine. CR/CRi rate was approximately 15%. I use Markibo these days when I take multiple refractory people, when I isolate and collect their T cells for CAR T. From the time that we do the engineering for CAR T, I use Markibo as a bridging chemotherapy, which works quite well. Instead of giving them significant cytotoxic chemotherapy, I keep their disease kind of in a stable condition until my T cells, my CAR T are engineered. One last case, we are almost about to be finished. 50-year-old female, history of HIV, controlled on highly active antiretroviral therapy with CML, started on imatinib. Because of gaining weight, imatinib switched to nilotinib. She didn't like to take twice-a-day medication, then switched to dasatinib. There were a lot of non-compliance in between. 2 years later, had a peripheral blast showing the BCR-ABL fish, showed the BALL had both transcripts of the P90 and 210. Treated with hyper-CVAD, BCR-ABL remained positive, switched to ponatinib. After ponatinib, achieved MRD negative CR, received haploidentical transplant from the brother, relapsed 3 months after that. At this point, the patient came to me. I started the patient on Blina salvage, achieved CR after the first round of Blina. I gave her 4 more cycles of Blina. I did not rush her to transplant. As good as with the MRD result that we knew, as good as I could, I debulked and decreased the MRD. And then after 4 or 5 months, I took her to the second transplant. Today, 5 years later, I see her now probably every 4 to 6 months. She remains in CR and is on ponatinib maintenance therapy, and she's doing great. She's back to work. She's working fully. She has no evidence of GVHD. A few slides about the CAR T. One of them is Kymriah. It's approved For people up to age of 25, you can find the information in the FDA label. It's good, again, for people that I use this product very rarely because, most of my patients that they're less than age of 25, with the CLGB or some other things, they don't get to the point that they need Kymriah. However, the ZUMA-3 study, the result of this study has been submitted to FDA. So we hope that by the end of this year, we see approval of this product. This is from the Kite Pharmaceutical. These are people with over age of 18 with relapse refractory BALL. People receive some conditioning regimen. They receive fludarabine on day -4 to -2, 900 mg per meter score of cyclophosphamide day -2. They were given 1 million CAR T per kilogram on day 0. And this is essentially 71 patients. They were enrolled in the study. This one was their ITT, intention to treat population. And finally, out of that 71, 55 received the CAR T. And as of September of last year, they had 16 months follow-up. And importantly, the CAR T was manufactured in more than 90%. This is very, very important. More than 90% engineering was very good. This one presented by Bijal Shah in EHA of this year, as well as ASCO. The manuscript very soon will come out in Lancet. These are some of the baseline characteristics. Essentially, you look at that, everyone had a primary refractory or significant relapse beyond the second line, or they had first relapse in the first year. Approximately 50% of people received Blina before, 22% received inotuzumab. So this is a very, very heavily pretreated population. And here you go. Even in that pretreated population, 70% of people achieved CR or CRI in that 55 people that they received their study. Even if you look at, I was actually talking with the people, with Bijal and the people in the company, and I said the ITT analysis is important. If you look at here on the lower part, the CR/CRI rate in all of the enrolled, which is all the intention to treat, even those, the difference between, even in those 16% that they never get to CAR T, the CR/CRI rate of 55% in this very heavily pretreated population is quite amazing. With that, thank you for your attention, and I will be delighted to answer questions. And I'm sorry, I thought we went a few minutes over time, but I'm happy to answer questions.
Thank you very much, Dr. Emadi, for this great and comprehensive presentation. So I do want to make sure that we go through questions, and I see one question which I will read in a second, but I wondered if my colleagues in Iran could make a quick comment in the chat box about the availability of the drugs, the new drugs like Belino, inotuzumab, or even the asparaginase. I'm just wondering, is there any problems with that? So if you can type those in the chat box. We do have a question from Dr. Rod, Surush Rod, actually a question that I was going to ask. So what is your approach in patients who have, the question is patients with 2 adverse risk factors, pH positive and hyperleukostasis or leukocytosis, I'm sorry, if the MRD becomes negative after induction. So in other words, I guess the other way of asking the question, if you're MRD negative, how do you look at the conventional risk factors, and maybe answering that question in pH positives and negatives separately?
That's a great question. Thanks for asking this. As of right now, the answer to this question is that for whatever regimen that you are using, after they achieve MRD negativity, you give them 1 or 2 cycles of consolidation, and you have to take people to allogeneic transplant. The standard of care now, as I said, this may change in a few years, But if you're fully positive, even MRD negative post-induction, based on the available literature, the best clinical outcome you can provide to people is to take them to myeloablative match-related allogeneic stem cell transplant.
Okay, great. Thank you for the quick answer. So we have a question from Dr. Pekar. If a patient develops asparaginase toxicity and you can't use it, how would you continue the plan? And the second question from him, is it better to use DEX instead of PRED because of a better CNS penetration?
I do the second question first. I essentially, the last time I used prednisone for people with ALL, I don't know it was when. I always use dexamethasone. So PRED is gone. The second thing is if they develop the toxicity, it depends on if they have a true hypersensitivity reaction, then you have to permanently discontinue. If they have a hemorrhagic pancreatitis, you discontinue. But if they have a little bit of grade 2 or 3 bleeding or some elevation in the transaminases or bilirubin and it goes back to normal, actually I start them on asparaginase. If the question is that we have to permanently discontinue asparaginase, which I've done 2 or 3 times for my patients, it's becoming a very challenging. I have a very low threshold to transplant these people if they are in MRD negative. Because if you eliminate the asparaginase from the pediatric-inspired protocol, you essentially eliminating the most important portion of that multi-agent chemotherapy. So for these people, I monitor them very closely. If they have a match-related siblings, I'm not saying that I transplant everyone, but I have a low threshold to do that.
Great. Dr. Biglari answered the question about the drug availability. It sounds like Blinatumomab and Inhibition are available in a selective manner. I assume financial aspects are important. Asparaginase is more readily available. Thank you. Dr. Pekar has another question. So if a patient has liver infiltration, which impacts the liver function before starting treatment, how would you approach that? This is my understanding from the question. You have a disease-related liver function abnormality or liver evidence of transaminitis or probably high biliary function problems. How would you dose your chemotherapy and what's your consideration?
That is a very, very good and practical question. So what I do, because in the CLGB, you can give a PEG asparaginase on day 4, 5, or 6. I actually switch or postpone asparaginase to the 2nd week. So I give them the steroid, they receive vincristine, and they receive a small dose of anthracycline. After debulking the disease, you will see that I've seen this multiple times. You will see that the liver enzymes will come down. And then I do this instead of day, let's say 4, I give it after the second dose of vincristine and anthracycline. You can get away from that. And the worst case scenario, if you're not able to give the asparaginase during the induction therapy, that's not a big deal. You can delete that. A lot of people doing it often for the older population. And you can give it during the consolidation or interim maintenance, and that will still be good.
Thank you. There's another question from Dr. Roth. Do you recommend haplo transplant in high-risk ALL patients in CR1? Maybe if I may add, so I believe in patients who you do believe that they have indication for a transplant, would you use haplo? And I assume the question is not necessarily if they don't have a related donor. So just using haplo as your preferred method for allo, and you coming from Hopkins, I'm sure you have your.
Yes. So the answer is yes. So if they have 4 and 11, because part of the stuff is that the CAR T, when they have MLL gene rearrangement or the Blina, they are not they're not working as much as we want in 4 and 11. So if someone has a 4 and 11 translocation or complex karyotype, or Philly-like, I definitely use haplo, and then the reduced intensity or haplo. The preference is that the intensity of the chemotherapy for myeloablative in ALL is more pronounced than AML. So I try to use the myeloablative regimen, but if for some organ dysfunction or age or some other stuff, I can't, I will definitely use the reduced intensity haploidentical transplanting dose.
Great. Question by Dr. Tavakkoli, a kind of similar question we had before. So you have a pH positive ALL patient, MRD negative after induction. They don't have a SIB match. Would you continue your kinase inhibitor, or would you push for an alternative donor like haplotransplant? In a way, I think you answered that question in the two prior. So if you can very quickly maybe summarize, that would be great. And we have more questions.
It depends on, again, this is something that I do, and this is something that probably some of my colleagues do that. So I'm in the minority. In that scenario that you said, if I have Dasatinib, not that much of the imatinib, because I think that Dasatinib is a better drug. And if I have ponatinib, if in case that they develop the T315I mutation, I do not push it for transplant. I have a army of 8 to 10 patients with Philly positive ALL that for different variety of reasons, I could not transplant them. One of them is a Filipino man, has no children, no brother, sister, parents are dead, and he has no match unrelated donor. So I have kept him on Dasatinib and a steroid and vincristine, and he is in remission now in 4 years. If you have Dasatinib and if you have the option of ponatinib, if they develop the T315I, I would not rush that person to haplotransplant. Having said that, if those options are not available, or if someone says that, I'm going to take this person to transplant because imatinib is the only thing that I have, that's not a wrong answer too.
Thank you. Dr. Mousavi has a question about, do you check MRD before and after allogeneic transplant in your practice?
Yes, absolutely. Not after transplant, but before transplant, we do. Essentially, in our center and many centers, probably is the same with Fred Hutch, Dr. Shadman, that actually there's a study that came from the institution that Dr. Shadman works in Seattle. If you take people with MRD positive to transplant, AML or ALL, the outcome of transplant is significantly lower or worse than alternatives. So in our institution, in my hand, I do not take anyone to transplant in MRD positive condition. I put them on, and that's the beauty of Blinatumomab. You can switch the MRD positivity to MRD negativity with Blina and then take them to transplant. And I have had, from the top of my mind, 4 of my patients that are still alive post-transplant doing well, and I did that for them, switch them to MRD negative with Blin, then take them to transplant.
Thank you. We have 2 questions very similar, so I kind of lumped them together. So after transplant, how would you manage extramedullary relapse? Or the other question is about testicular relapse. So I guess you can, in patients with or without GVHD, what would be your approach in those settings?
It's very challenging. Very challenging. It's an individual based. Unfortunately, Blinatumomab, based on the availability that we, or based on the data we have, does not have a great effect in penetrating the tissue, the extramedullary disease. So I tell you, if those patients are CAR T, if we have it here, I don't know you have it CAR T there or not. If they are CAR T eligible, I re-induce them with CAR T. I have actually had one patient that post-transplant relapsed and showed up with the spinal cord compression because relapsed in his T12 and then pressing on his spinal cord. So I gave him, he was 23 in that time, and I gave him Kymriah, and he achieved remission, and he is still in remission. If I don't have the CAR T, I wouldn't use Blinatumomab. Inotuzumab has a better tissue penetration, but believe it or not, I have had a few anecdotal personal experience with Markibo, which this is liposomal vincristine. Because again of the liposomal formulation of this drug, it has a very good tissue penetration. That one of my patients actually relapsed with a suprarenal. It wasn't adrenal, but with the tissue there, one relapsed with a mass actually in the testicular and one in the mass in the ankle. All three of them, I put them into remission, and all you need is that you put them into remission and give them DLI, or sometimes you can give a few fractions of radiation, provide some neoantigen before give them, but that's a very challenging, these are very, very challenging patients.
Okay, so I think, and Dr. Emadi, please let me know if you have to stop at some point, but I'm gonna lump two questions together, and after that, we'll open the microphone for Dr. Q-Mercy. So we have a question from Dr. Barhoum and also from Dr. Peykar, and I missed another question. I was just looking at it. But anyway, so GCSF, if you have somebody with fungal infection in the middle of induction and being neutropenic, do you use GCSF and stop chemotherapy? And the other one is like, does GCSF work during the Blinatumomab in a neutropenic patient? So then after that, we open the microphone for Dr. Q-Mercy.
I wouldn't do it. I definitely don't do the GCSF with chemotherapy. That's a contraindication. It causes, you can cure them from AML, you give them MDS a few years later. So if I have to do that, if I have to stop chemo and give GCSF and treat with, we have azoles here. I don't know if you have posaconazole there or not. Depends on the fungi. Is it Aspergillus? Is it mucormycosis? Is it Fusarium? So the type of fungal infection matters. It's okay, for example, if you don't give day 21 of vincristine during induction, if they have achieved empty marrow. During Blinatumomab, I never use GCSF, and I do not recommend that, because people that they are neutropenic, you can admit them, and then you can continue Blinatumomab, believe it or not, and then treat them with broader spectrum antibiotics. But I have never used GCSF with Blina.
Okay, Dr. Q-Mercy, go ahead.
Hi, Dr. Emadi. Thank you for your informative lecture. Actually, I'm a pediatric oncologist, but we have a joint clinic with adult oncologists in Shariati Hospital for ALL patients in the age group of adolescent and young adults. We use pediatric-inspired protocols such as BFM. And as you said, knocking on wood, our results are inspiring. But we have a problem with our TALL patients, actually. Clinically, we see more relapses in them. Do you suggest incorporating drugs such as bortezomib to our induction phase to lower our relapse rates? Thank you.
Great question, Dr. Q-Mercy. Essentially, whatever we as adult oncologists have learned from, for ALL, we have learned it from pediatric oncologists. And thanks to you and the wonderful, and as you know, the first ever cancer that was in 1937 was treated by Sidney Farber in Boston with the first drug, which was aminopetrin, the grandfather of methotrexate, was for children with the pediatric ALL. So the answer to your question is we do not use bortezomib. However, there is a COG study, the Children Oncology Group, that we have it here, and my pediatric colleague, we have that study, and I know that they incorporate the proteasome inhibitors such as bortezomib, Velcade into the backbone. I think the result needs to be mature before we using it or recommending it as a standard of care. As you know, MD Anderson has published their data of adding nelarabine to the backbone of hyper-CVAD. They presented in ASH for 2 back-to-back years, and then they published it. But when you look at the historical data of for TALL with regular hyper-CVAD compared to hyper-CVAD with nelarabine, not only the adverse events, particularly the neurological adverse events, was significantly higher, the response rate and prolonged survival rate is not better. So to directly answer your question, I think that it's a brilliant idea, but if I want to do it, I will do it in the context of a clinical trial. I will not do it in standard of care. As you know, bortezomib, even when you use it as a subcutaneous, has a significant peripheral neuropathy issues. And these children and adolescent young adults, we don't want, they have a foot drop or cripple them with some irreversible neuropathy.
Okay, I think we have 2 more questions and we'll be done. Dr. Bahri's question probably has a shorter answer, so I'll ask it first. pH positive patient after transplant, MRD negative, do you continue TKI?
So everyone in the United States, all of the leukemia doctor, they do that. However, I tell you that there's no phase 3 study to show that that's actually provide the benefit. But for all of my patients with Philly positive B or in rare cases TALL, if I take them to transplant, I tell them that for the rest of your life, you have to continue the TKI. This potentially might be challenging for some of the younger women that they want to be pregnant. But most of the women post-transplant, unfortunately, regardless of age, they go to menopause. So the pregnancy is not that much of the issue. So in my practice, I keep everyone indefinitely on TKI, granted that this decision is based on not a very high evidence data. Other people, there are some people saying that how about 5 years? How about 2 years? And the years are essentially the number of time that you rotate around the sun, right? So what is magic about 5 years versus 4 years versus 7 years? I don't know that. So unless people, they develop toxicity or their insurance, they cannot cover it, or for financial reason, personally, I keep everyone on Dasatinib post-transplant. I have seen a few people that post-transplant that they were not on TKI and they relapsed. I have a very, very young, I have a woman, 50 years old, Philly positive, went to transplant, achieved remission, MRD negative, went to transplant. 60 days later, relapsed. I gave her Blina. She had a severe, very severe cytokine release syndrome, which made me happy. By the way, cytokine release syndrome, if you see it, you should be happy. That means that your drug is working. And then after that, she is right now on cycle 6 or 7 of Blina. Now I'm giving her 4 weeks on, 8 weeks off. And I told her that I'm going to give her a total of 9 cycles. This is based on the original Tower study. And she's on Dasatinib, and I give her 1 dose of intrathecal methotrexate with hydrocortisone with each cycle of Blina IT chemo. And she's doing great. She just recently became a grandmother. She has a wonderful 2-month old grandchild. And every time that she comes in and she shows the picture, yeah, so I keep them on Dasatinib essentially for the rest of their life.
Okay, so we'll finish with this question from Dr. Peker, who actually has two questions, but I think I want to be respectful to everybody's time. And Dr. Peker, you can definitely reach out to Dr. Emadi with your second question. I think the one that may be more applicable and more general question is, which may require a new lecture, Dr. Emadi, pregnancy and ALL.
What about it?
How would you treat ALL in a pregnant patient?
So again, that depends, as you said, this is probably half an hour lecture, so you cannot, you can give it depends on which semester. You know, the first semester is much more challenging. The second and third semester, I treat them with chemotherapy. You can give anthracycline to pregnant women. You can give a steroid. You can give cyclophosphamide, not vincristine. You can give methotrexate in the second and third trimester. So if in the first trimester, I try to keep them on a steroid, no hydroxyurea, and then, of course, you need to have a consultation with high-risk gynecologists. But in the second or third trimester, essentially, for most part, I consider that they're not pregnant, and I treat them with a CVAD, modified CVAD regimen. And then after the delivery of the baby, you continue with whatever regimen that you chose.
Okay, thank you very much. I think this was an outstanding talk and a very good discussion, many questions from our colleagues. And thank you again, Dr. Emadi, for your time on Saturday morning. And thank you very much for our colleagues in Iran and from other places. And I think with that, we'll finish here. And I don't know if Dr. Yaghmai has any words to say at the end, but I think it will be done for us. Thank you very much. Have a good day. I think she doesn't. So bye,
Thank you very much, everyone. You have been a great audience. And Dr. Yaghmai, thank you very much for inviting me. Dr. Shadman, thank you very much for being such a wonderful moderator. And have a great day or night. And hopefully we see each other soon. Bye.